Hello, everybody. Welcome to the latest LPAT podcast. That's the ethics, legal and psychosocial aspects of transplantation section of the European Society of Organ Transplant. I'm very delighted to have my colleague and friend, Jelena Stojanovic, as our guest today. Jelena is one of the paediatric nephrologists at Great Ormond Street in London and also a member of the paediatric section of LPAT. Jelena, good morning. How are you?
Good morning, Joe, to you and to the LPAT listeners. I'm very well. Even better to be on this podcast.
Excellent. So to start off with, could you tell us about your career and interest in transplantation, please?
So I have been a transplant nephrologist for the last 10 years. And I've worked in 3 transplant centers in the UK. That's Newcastle upon Tyne, Evelina, London, and since 2017 as consultant, I've been working here at Great Ormond Street Hospital for Children. My general pediatric training was initially in the Newcastle, and that's when I got introduced to the pediatric nephrology and to also the field of renal transplantation. The interest really furthered once I moved to London for my subspecialty training, and as everyone, I also had someone who has actually made an impact on me and actually made the transplantation an interesting topic or an interesting field. And that was one of the transplant surgeons in London at the time, Professor Lisa Lamott. So as a trainee, I had opportunities to participate in a lot of research projects in the field of transplantation and got introduced to the ESOT at a conference in 2013. So that's how it all started.
Cool. I guess given this is an LPAT podcast, there are 3 areas that the section focuses on. Which do you find the most interesting or challenging? We all like all 3 of them, of course, but ethics, legal aspects, or psychosocial aspects of transplant medicine, which do you really think is the most interesting for you personally?
That is a hard one indeed, and I appreciate that you realize that as well. I think when I started and when I working in the transplantation, and certainly when I joined ESOT, because I was an AKITA board member for 4 years before I joined.
And just explain what AKITA is to the listeners.
Yeah, so that's the European Kidney Transplant Association, and it is a section of ESOT under the umbrella. So just like LPAT addresses ethical, legal, and psychosocial aspects of transplantation, AKITA focuses on anything to do with kidney transplantation. So I was a board member there and then moved on and joined Pediatric Donation and Transplantation working group under the umbrella of LPAT. So when I started that work, and that kind of coincided with very early start of my transplant nephrologist career, my initial interest was on the ethical side of LPAT, and particularly the ethical side of transplantation of children, because what has happened in the last couple of decades is that we are now seeing more and more children with complex conditions, with multiple comorbidities, surviving outside the infancy. And those children are actually coming up as the transplant recipients and candidates for potential kidney transplantation. Now, when we are faced with conditions for which we do not know what the long-term outcome is, that raises a lot of questions, and some of that would be, is it ethical actually to offer a major surgery and treatment in view of kidney transplantation to children for whom we do not know what the clinical outcomes would be. And so that's how it started, and that was my initial drive of joining the LPAT. I joined LPAT in 2019, so it's been about 6 years now that I've been within the group. And that interest slightly changed, actually. So I think I need to move to the second letter of the LPAT, to the legal aspects. And the reason why I maybe find the legal aspect now a bit more interesting, well, firstly, because you are the PDAC chair now, so you're focusing on, you're the better person to focus on the ethical side. Exactly. I discovered that what I've learned is that there are differences in what kind of transplantation or what type of transplantation is allowed or actually in one country, for example. There are European countries which, for example, do not have the legislation to allow DCD kidney transplantation, and that's something that I've learned alongside my work with ALPAT. So I think now my focus will be more on the legal side of it and actually how do we make transplantation equitable across the world, actually. And why are there legal obstructions, if you want to call it like that, in some of the countries and not in some of the other ones?
Fascinating. I think it's a really important area for us to explore going forwards. But one of the best things about working in Europe is so many different countries coming together. But there are some distinct areas like the law, which are national based, which, in terms of withdrawal of life-sustaining treatment, countries have very traditional reasons that's developed in that country. And so, that's a fascinating area which we will be exploring. I guess, Jelena, the next thing to think about, you've done a lot of work together with Nikos, a transplant surgeon, setting up transplant programs for children in countries where they haven't previously existed. I'm interested in kind of some of the challenges you may have faced with that. Could you explore that with us, please?
Yes, where do I start and how long do you have if you're going to talk about this?
Sure.
So we started a working group which just initially comprised of 2 surgeons, transplant surgeons, and myself as a nephrologist. And we started this group, transplantforkids.org, which focused its effort to try and improve the transplant program within the pediatrics in a lot of countries. And initially we started in 2018 with Serbia upon the request from their university to try and improve the education. Now, over the years, that expanded and included other countries such as Cyprus, such as Greece. We are now setting up an education program in Montenegro as well, and working with ESOT on the Balkan Initiative as well. So the learning from that, for me, is that one model will not fit all. And although we knew about that before we started, and we always aimed to personalize educational programs so that the team that's inviting us to improve their education program, these are mainly developing countries, but although you've heard the names of the countries where we are involved, it involves some of the developed countries as well. You're aiming to personalize the program and to deliver what the team needs, but often there is a big discrepancy what the team perceives that the needs are and what the actual needs are when we are assessing. So that is the first thing that became very obvious.
Jelena, have you got an example of that? I think it's fascinating that you come in more experienced in transplant medicine and maybe local teams, that's where your expertise would be helpful. There are issues they think in one area, but actually the area that needs sorting out is somewhere else. Have you any kind of details about that?
Yes, I can give an example. So, for example, when we started the pediatric living donor pediatric transplant program in Serbia, the initial request came from the team which was already doing the pediatric transplants, about 2 or 3 a year, so not high numbers, but they didn't have surgeons. So they said that there were 2 surgeons at that time who were doing kidney transplantation for children, and they both left at the same time. So the team, the pediatric nephrology team, was there left with a cohort of children on dialysis. I think we calculated we had 37 children on dialysis with potential living donors, but no surgeons to operate. So this is huge. And our initial visit over there was to see how do we ensure and train the junior surgeons over there to make the pediatric transplant program in Serbia sustainable. Now, over the months and years, and obviously we were prevented to go there for a couple of years because of the global pandemic, but what became transparent is, yes, there is definitely a need to train surgeons who are willing to learn and to be trained by some of the top class surgeons in the world. But there was also a lot of old-fashioned practice and not up-to-date practice, which should be research-led and evidence-based within the pediatric nephrology. So, for example, the current approach in Serbia is that you are not put for the transplant assessment. So we're not even talking transplant surgery, for the assessment for transplantation unless you start dialysis.
Right. So there's
Now,
a block there. Yeah.
there is a huge block, and that is in people's perception. And I'm talking nephrologists. I'm not on this one. I can't blame surgeons. Okay, for everything else maybe, but this one needs to go down to the nephrologist. And when we further explored that, it was just the perception from the very old-fashioned way that a child ends up on dialysis. That's when you start work up for a transplant. But now, for many years now, the golden aim is for the preemptive kidney transplantation for children. That means that having a kidney transplant before you actually end up needing dialysis. So, that's maybe one of the examples that I can think of now, and that actually led. The furthering work over there led to discovering the other gaps in the knowledge. And that's not uncommon, Joe. The gaps in the knowledge are not uncommon when we are talking about services or transplant areas which don't have as high numbers. We know that pediatric transplantation doesn't have as high numbers as the other transplantation. So the focus of the team, for example, in Serbia was mainly to assess to put children on dialysis and then start slowly to work them up. When we started, for example, there was no unified list how many children are on renal replacement therapy in Serbia. Who are they? When did they start dialysis?
So there's a real a lack of demographic knowledge to help you set things up. That's kind of key, isn't it?
Yes, that is key. And I think I would like to at the end of May, actually, ESOT has published a very good document, which is a guide for improving the transplant programs within the Balkan area. And it's got 6 pillars in it. And that's exactly the key thing, as you're saying. One of them is the demographic assessment, because there are different models for different countries. And this is what we are now able to actually offer. So Serbia has the adequate number of pediatric children, patients with end-stage kidney disease to make the independent, sustainable transplant program, meaning that at some point when we finish our work with that center, they will be able to run the living and deceased donor kidney transplant program independently. Some other countries, for example, Montenegro, it is not feasible to have independent transplant program because of the numbers, because they are too small. However, it doesn't mean that that country needs to send children to go abroad to have kidney transplant. There can be various visiting teams who can comprise from the surgical and nephrology and aesthetics side as well, who can come and then do the operations over there. Now, one question that I got asked was, well, what's the benefit for the local team if they will never be independent in doing these surgeries, for example? There is a huge benefit because the surgeons who are assisting our transplant surgeons are actually learning how to manage some complications. Kidney transplantation, for example, is a vascular surgery. So there can be a lot of intraoperative techniques that the local team can learn that can be then utilized for some other surgeries. And I know that the current Akita President Barish has been visiting for years now, colleagues in Albania, and he's based in Istanbul in Turkey, and he goes and he supports their program as well. So there's various models that can be, but the challenges are actually the awareness of the local team, actually, of where the gaps in the knowledge are. And second thing is probably something that you and I experience here as well, is the change management and change in people's approaches and how to actually lead. And how do you lead the team through the change? Because people can be in some parts of the world, maybe more than the others, can be quite sensitive to any comments, which can be then interpreted as criticism rather than as constructive feedback on how to make things better.
So that's fascinating. So that's really how, Nikos Kerseris, we should say, is the transplant surgeon we mentioned earlier you work with.
Yes.
At the Evelina and Great Ormond Street. A great team you two make. But the idea that you can't just parachute in, you have to work with local teams, do demographic work, and help make this a sustainable process for smaller countries as well as bigger countries, something that, you affect real change, but also when you leave, that change doesn't wither and die. It has to be sustainable. And it's so important for the children of that country, isn't it? To think about the practical aspects, but also the change in attitudes. I like that there's maybe, and we've come across them throughout our career, kind of long-standing, old-fashioned ways of doing things. I'm sure my fellows think I do that now, to be honest, Jelena, but it's kind of how medicine moves on, isn't it? So super important to do that.
Yes.
So moving away from that program, and you can read more about how those things are done in the SOT documents. Our next LPAT Congress is going to be in Sevilla in October, which will be on the 9th to 12th of October. And what are you most looking forward to in that Congress? What do you really think, I really want to work on that or think about that or listen to? What's the main things that you think are going to
Yeah. So so one of the things that I'm mostly looking forward to that meeting in Seville in October is actually networking with people from various working groups within the ALPAT, but also remembering the last meeting that we had a couple of years ago in Oxford, where actually it is one of the groups where you come out of that meeting with some clear plans and aims of what projects are we doing, and actually clear timelines as well. So that's the first thing, because to me, and as I said, I've been on the equitable, for me, that is one of the things that is making ALPAT stand out from some of the other sections. It is that there is a focused couple of day meeting where actually there is an outcome of that with plans for fantastic research projects and collaborations as well.
And deliverables, as you said.
Deliverables, yeah. So that would be the one thing.
Yeah.
Yes.
Good. Okay. And so I guess as the pediatric group of the ALPAT, we've got a lot of work to do, because pediatric transplantation, for good reasons, is a fast-moving, developing field, isn't it? With not many people working in it compared to the adult areas, I think. So lots of opportunities, but lots of work. So it's all good stuff. I guess maybe to finish off, I'd like to pick your brains, if I may, Jelena. So what do you think are going to be the biggest challenges in pediatric transplant going forward?
Well, if we think about the next 10, 15 years, my anxiety, if I would say that, about pediatric transplantation is that is the lack of awareness of our adult transplant colleagues about the complexity of the children that is coming through to be transitioned to them.
Excellent.
I think that is,
I can see that. Yeah.
That is something that I'm really anxious about, and I'm aware that a lot of transplant organizations, and including ESOT, are working hard of actually building sustainable transition programs. And that can only be done with very close collaboration and interaction between the pediatrics nephrologists or pediatric healthcare professionals and those working in the adults, which can sometimes be easier said than done. But that is I think that will be the biggest challenge is that although that we'll be able to transplant these children who are much smaller these days, because we are able to offer, if we have the time, I just wanted to take you through the kind of journey of the current pediatric renal transplant recipients.
Yes, absolutely.
It starts from basically the neonatal period. The huge advances in the neonatal medicine have now allowed the children who are born with congenital kidney anomalies, which, by the way, form about 40% of the reasons for end-stage kidney disease in childhood. They're able to survive outside the neonatal period in infancy because the support for the chronic lung disease that is available, and actually the colleagues, and I have to commend here the colleagues in neonatal medicine doing a fantastic job keeping these children alive. That then brings a challenge to us in nephrology services, because we are inheriting the children who need dialysis from very early ages, even a few months of age. That then means that the children will be younger when they will require the kidney transplant, which then means that a group of children might require another kidney transplant in the childhood. And let's stop there and let's just think about complexities of that pathway for a patient, for a patient, and that's to be delivered in the childhood and adolescence. And we know that is the most important period of anyone's life. This is when children grow, when they have their physical and emotional maturity, when they build their social context, and most importantly, when they get the mainstream of their education. So, and then you add your comorbidities. They might have a liver problem or a heart problem or some neurological condition and so on. So the fact that we are able to transplant these children is that how our colleagues in adult setting are not used to managing these patients and collaborating at the level that the collaboration needs to happen. Their cohort of patients is the kidney transplant patients with some cardiovascular diseases, plus or minus something else. Our patients are coming with at least 3 or 4 specialist teams involved in their care, Joe. And I think if we don't really work on the transition, probably we are going to see that all these children who have so much input of so many multi-healthcare professionals are going to end up losing the kidneys at the time when they're transitioning to the adults or very shortly after. So that continuity, ensuring the continuity of the care into the adults, I see as the biggest challenge.
And yeah, I absolutely. And it's interesting that the new paradigm of children surviving that wouldn't have survived before is across all fields of medicine, right? And so,
yes,
your classic group there, the child with pulmonary hypoplasia from antenatal, postnatal issues, then ends up getting managed aggressively to get to a kidney transplant at 1, and then does quite well for a time. But as you say, a second transplant in childhood is kind of not something that have happened 20 years ago.
Yeah.
And so this is kind of a new paradigm. And then into the adult world and children having maybe multiple complexities, other issues, and then that multidisciplinary pediatric approach being maybe not quite mirrored in all adult settings. And that's how it is. That's how medicine's developed. And so I think there are big things that need to be addressed and changed. And then I guess in some ways our experience of that is largely UK based. And so, that also needs to be set up for children in Serbia. So at the minute you're looking at the acute transplant, because that's quite a recent thing, 10 years, 20 years, that'll be the things they will start to come across as well. So across Europe, people at different stages of this journey, right?
Yeah,
and there are really interesting things to consider in a broader level. So the good news, thinking about ethics, legal and psychosocial aspects of transplantation, will never be fixed. It's going to be there forever with new challenges as we develop the speciality. And it's greatly interesting. And so we look forward to seeing people at the Congress, but also encouraging people to come and work with us to think through these challenges as we move on in medicine. So Jelena, thank you so much. That's been really interesting. Lots to think about and work on further. But for now, this has been the Ethics, Legal and Psychosocial Aspects of Transplantation podcast. I'm Joe Briley, and I'm the podcast host. Thank you, everybody. Our guest today has been Jelena Stojanovic.
Thanks for having me, Joe.
Thanks, Jelena. See you next time, everybody.